Let's talk about pertussis. This chart shows the trend of pertussis infection for the last century. As indicated, vaccination had greatly depressed pertussis infection. The annual pertussis infections were kept under 10,000 cases for 38 years from 1965 to 2002. Then, the numbers started to climb up again. During the outbreak in 2012, pertussis infections surged to 48,000 cases. What was clinically significant in this outbreak is that the infection affected beyond its formerly prevalent population. At this time, adolescents and adults were infected. This outbreak extended immunization schedule of pertussis to include children going for middle school and boosters for adults. Here are the objectives for this lecture. Analyze factors that put the client at risk of infection of pertussis. Identify the cardinal signs of pertussis. Formulate individualized nursing care plan according to the client's need. Prioritizing nursing interventions. Analyze client's needs and provide appropriate patient education. The responsible pathogen causing pertussis is a bacillus, rod-shaped bacteria named Bordetella pertussis. It commonly affects infants, especially those younger than 6 months old. The single most significant risk factor is lack of appropriate immunization. Pertussis is a respiratory infection, and it is transmitted via direct contact of the contagious respiratory secretion, including inhalation of the droplet. After a person contacts the contagious droplet, Bordetella pertussis starts to replicate at the respiratory tract. At this time, the infection is at the stage of incubation, during when patient is asymptomatic but could transmit infection to the next victim who contacts the contaminated respiratory droplets. As a matter of fact, incubation is the most contagious time. Incubation could last for 6 to 21 days, usually 5 to 10 days. Then the infection progresses to catarrhal stage, in which patient manifests with initial symptoms, like having a cold, for another 7 to 10 days. These respiratory symptoms include nasal congestion, running nose, and cough lasting 1 to 2 weeks. Patient can have low-grade temperature. If the patient is not treated appropriately, the communicability time could last for another 2 weeks after onset of cough. Paroxysmal stage follows with the cardinal symptoms of paroxysmal coughing, whooping sound during inhalation, and copious respiratory secretion. The characteristic coughing is rapid and consecutive, 10 to 30 times in a row. A forceful inspiration follows, creating a signature whooping sound as air passes through the narrowed airway. Then, abundant and copious respiratory secretion, saliva, emesis, and tears are evident. During paroxysm of coughing, infants younger than 6 months old may experience gagging, gasping, or even apnea. During coughing and forceful inspiration, patient's face might be flushing red. As the airway is narrowed, note the cyanosis indicating oxygen deprivation. Paroxysmal stage could last mostly 1 to 4 weeks. Pertussis is self-limited. Convalescence takes a slow pace. It might take the client up to weeks or even months to recover. Complications of pertussis are more severe in infants, such as pneumonia, apnea, encephalopathy, seizures, or death. For adolescents, complications of pertussis include sleep disturbances, incontinence, syncope, rib fracture, or pneumonia. The younger the age, the poorer the prognosis, especially for those who are younger than 6 months old. Their mortality rate is 1.6%. Prevention is the best treatment for pertussis. Therefore, schedule vaccination. Keeping the client at droplet isolation is another prevention method. It prevents the spread of the infections. Medical diagnosis incorporates history intake and physical examination. However, it is confirmed by nasopharyngeal culture, polymerase chain reaction, or serology testings. Medical treatment aims to eradicate the bacteria, prevent spread of the infection, and support the respiratory recovery. To prevent spread of the pathogen, the client is kept at a droplet precaution until 5 days after initiating effective antibiotics. When administered during catarrhal stage, antibiotics can better control symptoms. But if the antibiotics are started at a later time, they can only reduce communicability. Antibiotics are also used for both treatment and prophylactic purposes. To treat infection of pertussis, macrolides are the choice of antibiotics such as erythromycin, clarithromycin, and azithromycin. Macrolides are antibiotics that irreversibly bind to ribosome, inhibiting protein synthesis of the bacteria. The most common adverse effect associated with usage of macrolides is GI irritation, such as stomach upset. Transient deafness was also reported with usage of erythromycin. Macrolides can prolong QT interval. Therefore, they should be used with precaution on patients with cardiac concerns. For those who are allergic to macrolides, Bactrim is the alternative. A prophylactic treatment by using full course of macrolides is recommended for all close contact family members. In addition to prophylactic antibiotic treatment, vaccination should be added if a close contact is younger than 7 years of age or is inappropriately immuned. Throughout the course of pertussis infection, support to respiratory system is essential. Infants younger than 6 months of age or patients with severe infection should be hospitalized. Vaccination is the key to prevent infection of pertussis. The population at risk for pertussis are people who lack immunity or are inappropriately vaccinated. DTaP is given to infants and children under 7 years of age. This is a series of 5 doses given at 2 months, 4 months, 6 months, between 15 and 18 months, and then 5th dose at between 4 and 6 years of age. Tdap is then given at 11 to 12 years of age. For adults, Tdap should be given every 10 years to boost immunity against pertussis. In order to provide protection for the newborn, vaccination is recommended for both expectant mothers and fathers. It is recommended to vaccinate expectant moms at 3rd trimester and dad before birth of the newborn. Pertussis is a reportable disease. Once pertussis infection is suspected, droplet precaution is initiated until 5 days after effective antibiotic therapy started. The choice of antibiotics is a full course of 14 days of erythromycin or other macrolides. Patient education emphasizes on taking medication on a strict schedule as ordered to avoid resistance to antibiotics. To enhance absorption, it is recommended for the patient to take the medication with a full glass of water 2 hours before or after a meal. However, if the patient experiences GI irritation, then it is better to take the medication with food, but not with juice. Also, monitor the patient for adverse effect of hearing impairment. The top priority when providing nursing care to a client with pertussis infection is airway patency. Emergency equipment should be kept available. Oxygen and gentle suction might be needed. The infant's need should be met immediately to prevent triggering coughing spells. Cool mist humidifier is encouraged to soothe the airway. Fluid intake should be encouraged as tolerated. Stay at bedside during coughing spells. Monitor the airway and respiratory status. Provide emotional support to both the client and the family. Infant younger than 6 months of age or patient with severe condition should be hospitalized. A calm and restful environment with decreased stimulation will help reducing spells of cough. Encourage frequent rest. Frequent and small feeding can help conserving the patient's energy. Providing patient education regarding medication administration, disease process, vaccination needs, and signs and symptoms of respiratory distress, respiratory failure, and dehydration, especially when the patient is being cared for at home. Patient education should also include monitoring and reporting adverse effects of antibiotics. Thank you for taking this lecture with me.